Welcome to The Ultimate Asset, the podcast where elite physicians, health strategists, and high-performing leaders explore what it really takes to protect and elevate your most valuable assets, your body and your mind. This is high-performance medicine, powered by Velocity Health. Welcome back to the Ultimate Asset Podcast. I am Dr. Deep, your host and founder of Velocity Health. I am joined by my co-host, Brock Reichert, our other co-founder, and one of our wonderful physicians, Dr. Dan Fosselman, today to speak about a topic that is near and dear to all of our hearts as men in the room and as physicians and clinicians who take care of a lot of gentlemen who come to us with the question around testosterone optimization therapy. So we are going to go deep today, talk all things testosterone, mostly for the guys in the room. There will be a lot of pearls here and interesting things for all to learn from, but we will be having a separate episode on women's health and women's hormone optimization therapy with a few of our other physicians as well. So stay tuned for that as well. But let's welcome Dr. Dan Fosselman. Thank you for being here, Dan. Welcome.
Thank you for inviting me to your party.
It's always a good one. It's a good party.
Dan, do you mind giving a little bit of a background introduction on yourself? You have too many certifications for me to even remember and list, but one of the most well-trained and down-to-earth physicians I know. But do you mind just giving us the minute background on your training and history and how you came to be a doc at Velocity?
Yep. So as a biochem major at Denison, super into strength and conditioning at that time, had no clue what I was going to do with my life. So I went to medical school at a DO school up in Erie, PA. Then I again didn't know what I was going to do with my life. But fortunately, I found this awesome mentor, a guy named Eric Serrano, who was a national expert on nutrition, strength and conditioning, hormone optimization. And I just said, I want to be like this guy when I grow up, maybe not as crazy, but he loved his patients and was a lifelong learner. And he just taught me and keep learning. So I'm dumb and I just pay a bunch of money to keep doing certifications to stay up to date. And then met you serendipitously and said, I would love to help you out. You're a great visionary, great entrepreneur, and you love your patients and people. So I'm glad to help.
Well, thank you, Dan. I think you have, 4 board certifications. You're family medicine, sports medicine, lifestyle.
Anti-aging, regenerative, lifestyle, functional med, ringside medicine. I think obesity medicine.
And
I'm envious. Damn, that's
yeah.
I feel like a little.
You're a lifelong learner, and I think just to toot our own horn, we bring some of the best doctors to the table, clinicians to the table, people who have real experience in working across all sorts of different fields and expressions of what we're talking about here. So you've seen a lot of guys with low T. You've taken care of a lot of men and patients who are looking to optimize their testosterone. So we're excited to get into all sorts of topics with you today.
Absolutely.
Awesome.
Well, yeah. So I guess, Dan, we were talking offline. What is the most interesting thing that you have discovered about just testosterone in general that you were just telling us?
Yeah. So it was discovered back in the day. It was isolated initially from rooster testicles, and then they started castrating bulls, mashing it up and ingesting it, and saw that there were some vitality benefits. And ironically, just looked it up. The guy who was doing that was Dr. Koch. So Dr. Koch and McGee back in 1927 were isolating testosterone. Fast forward 100 years, and here we are.
Dang.
Love that.
It was meant to be in the historic context there.
Were they like grinding these things up and taking it just to like get the vitality, and they thought it like made them better warriors and fighters, and what was the theory?
I think it's, we probably had less IRB criteria or animal research stuff than now. And
Right.
we're just like, hey, let's see what happens. I mean, clearly you had eunuchs back in the day and they noticed, voice changes. There wasn't as much risk taking, and that probably has been going on for 400 years. And then people started experimenting with animals. And then of course you have humans who say, hey, let's just try things and see what sticks. And over time we just accumulate knowledge.
Epic. It's like always a funny thing when you think about the discovery of some of these, I guess, what seems like basic stuff to us now, but these guys doing this cool experiments back in the days would be kind of a cool, like, fly on the wall to be when these guys are doing this stuff, crushing testicles and eating it. Kind of the format of this episode is, since I have the pleasure of having 2 really good docs here who've done a lot of TRT work, who know a lot about TRT and testosterone, is I'm just going to kind of go through and ask these guys questions. And we're going to kind of roll through, starting with like just natural testosterone and how to get that up and kind of the decision-making stuff on getting on TRT, followed by like lab analysis, kind of things we're looking for in the labs, and then followed by like kind of the best ways to do TRT, the things we're doing wrong, and kind of all of these sort of things with the actual administration of the prescribing of testosterone replacement therapy and how to optimize that. So yeah, I mean, the first question would be do we really have a low testosterone epidemic here, guys? Like, is testosterone being low a real concern, or is this just good marketing around these companies who are selling testosterone?
My answer is both. So when you look at the literature, there's clearly a decline, over the past 30 years in testosterone levels. And, from the functional medicine standpoint, it's all because we're drinking out of plastic water bottles and it's BPA. But the more likely answer is we are just, as a society, less metabolically healthy. So more obese. Post 2020, there's a lot more alcohol intake, narcotic use is on the rise. People are more sleep deprived and they're less active. And when we talk about how can you naturally increase testosterone, well, it's get adequate amounts of sleep, exercise consistently, maintain a healthy body weight, don't drink too much, definitely don't abuse narcotics. And you can get a significant increase in your natural testosterone level by doing those things.
Yeah, I totally agree. I mean, it's undeniable that we are seeing a population level decline in testosterone levels. I pulled a couple of studies here just to cite these. So one of them is a large study, Travison et al., Massachusetts male aging study. This looked at patients over a 20-year period from 1987 to 2004. And they showed that median testosterone levels basically went from 500 down to 391. So 20-25% decrease there. Another large adolescent study looking at the NHANES data over 3 decades. From 1999 to 2000, the mean testosterone levels were 605. Once we got to 2015-16, those are already down to 451. So nearly a 50% decrease, like over 20 years over all of our lifetimes. And, it's observational data, fine. Like there's all sorts of things. I totally agree with Dan. Like there are probably major environmental drivers like microplastics and BPAs and phthalates that we are understanding now and I think starting to address. But I 100% agree. Like the biggest driver is probably just obesity, frankly. It's just that and inactivity. The amount of aromatization that we have as a population now, just given how much extra adipose we have, is astronomical, right? And like that's obviously leaching testosterone levels, but it is not a false statement to say that we as a population are a much lower testosterone population than we were 30, 40, 50, probably hundreds of years ago as well.
Do you guys think a lot of these factors are like, let's say, some of the environmental issues, obviously the sleep, the metabolic issues, these things can be reversed pretty easily, but for someone who's already doing those things and maybe like they can't get away from maybe air pollution or any of these things, like, is it actually possible to get testosterone up to a point that's like back to this older kind of ancestral levels in this day and age?
I mean, my answer is that yes, it's, you have to do all the hard things, right? And that's the hard work is you actually have to get down to lean body weight where our ancestors probably were. And like, if you were doing all of the right things, would we still see a lower level across, like an age matched person 50 years ago? Probably, it's hard to know on an individual level, but I do think each of us has an opportunity to maximize our own sort of potential by pulling the right levers. We talked a little bit about the natural ways there. I think I really see it as this spectrum when people are coming to us and we're talking about low T and correlating it with symptoms and realizing that there may be something there. It's these lifestyle things for sure, right? Life, circadian rhythm, sleep, exercise, sex, competition, all these things. There's a slew of supplements, I would say, that have equivocal data, and we should go into those, Dan, I think, from like a natural quote unquote side to try to boost T. There are others that are like working on the brain. Now you're getting into the medication kind of setting, and then you get to full on TRT. But, outside of those big lifestyle factors we talked about, Dan, are there anything else like from a lifestyle standpoint you think about?
Yeah, I think the archetype we've been describing so far about why someone has low T is these extremely out of shape people. And like, I think in our patient population at Velocity, we have a lot of high achievers. And I would even say burnout causes a lot of the same symptoms. So they're like, hey, I'm working out at CrossFit 30 hours per week, and I'm working 100 hours with, my company that I started, and I have extreme amounts of stress. And I'm also trying to be a good father and parent and manage my personal finances. Those burnout people too, you get a reduction in the value of testosterone.
Mm.
So it's kind of, we're so extreme. It's like you have complete sedentary people, low testosterone, and your alpha entrepreneurs that can get the exact same thing because on paper they think they're doing everything right, but it's like they have overtraining syndrome, but it's like overtraining of life syndrome where there's way too extreme on everything, and that can also reduce levels.
It's like allostatic load is hard on one direction for some of those guys, and then for the obese ones, it's loaded over here on like the obesity, metabolic, unhealthy inflammation kind of thing. But well, you guys,
Maybe
what?
one
Tell me
thing
this.
we can just back up and define for people, Dan, is like when someone comes to us with symptoms of low testosterone, like what are some of those symptoms, first of all? And then second, maybe we could both talk through like primary and secondary hypogonadism and how we think about those differently.
Yeah, and even taking a step back is when you talk about hormones as a general class, okay, they are systemic, meaning they impact kind of every area of your body. And so this is why like low T centers, it's like you name any symptom, it could be a potential symptom of low testosterone. Well, fatigue, depression, irritability, low libido, decreased body mass, lack of concentration, brain fog, like all of those things are potential symptoms of low testosterone. So like the formal academic answer is there's the Adams H questionnaire. You can go on that. It's like, are you irritable? Are you not getting amount of sleep? Is your libido decreasing, concentration? But like almost any symptom that could be kind of anything, even depression, could be caused or associated with low testosterone. So hormones just are so diffuse where it's not like this one thing or one symptom that defines if someone has low testosterone.
If someone's like on the lowish side, like say they come to you and they're 300 or 400 and they've got fatigue, like how do you approach that? At what point are you thinking this could be testosterone versus everything else? Are you like ruling everything else out first? Are you trying to stop like hormone replacement first, or what's your approach?
Yeah, so to me, it's on my standard panel. And the reason for it is this, is I view testosterone as a surrogate marker for someone's overall health. Okay. So if someone comes in and they have a great, robust testosterone level, they're probably doing most things right. Are there exceptions to that rule? Of course. But I to me, I try to think of what are valuable labs. And for a male patient, I mean, in today's society, it's really like above 18, you're seeing these low values. I just kind of throw it on the standard panel. It's not too expensive. And a lot of guys now they want to know that marker. So if I can just take a peek at it, whether I'm going to treat it or not, it is something I can track over time as a surrogate marker. Is this person getting healthier, even if I'm just using lifestyle interventions?
What do you see else, like when you're looking at a lab panel and deep, like what are you guys also really looking at when you're kind of viewing someone's physiology just from a lab perspective? Like when in reference to just like when you see a low testosterone,
Like
what are their markers?
I mean,
Yeah,
I
what
think
else are you looking at?
what are the actual labs we're looking at? We're looking at total testosterone, free testosterone in our, this is what our panel looks like. BG, so sex hormone binding globulin, looking at a estrogen marker like estradiol, E2, prolactin. And I think there are all these other things that kind of filter into that. We do get Dutch tests on some patients, which also include all the metabolites, includes a DHT level. We check blood DHT levels as well. And lastly, there are these vitamin D levels, for example, right? Or magnesium, things that are cofactors in helping to produce these things. So we go pretty deep, I'd say, and get a pretty extensive analysis. Dan, what else would you add to that?
Yeah, I try to simplify, and the answer is like, is this person healthy or not? I was heavily influenced by this doctor, Mark Houston, who is a vascular specialist at Vanderbilt. And he's like, there's an infinite number of stressors and three bodily responses. It's immune dysfunction, inflammation, and oxidative stress. And so what do I look at a minimum marker? It's like I get a CBC, that's the immune dysfunction. I look at a high sensitivity CRP, inflammation, and GGT, the surrogate marker is the surrogate marker I get for oxidative stress. Those things, in addition to testosterone, I think are really helpful. Kidney liver function is, again, metabolic health. Like, does this person have fatty liver? Lipid A1C, again, is going to be looking at more of how metabolically healthy someone is. So if I can look at their cumulative stress level with 3 surrogate markers, look at metabolic health through a couple surrogate markers, that gives me 80 or 90% of the total information I need to get a picture of what is this person's health. And honestly, this machine behind me, if you can get a body composition analysis, that is probably the biggest bang for your buck that I have, where it's like, well, is your visceral adipose tissue good and how much skeletal muscle mass do you have? If your muscle mass goes up and your visceral adipose tissue goes down, guess what? You tend to get healthier. So it's kind of simplifying that entire approach to a patient. My bad joke is I'm dumb, so I need less information to make decisions on, and simplifying it has really helped me.
It's almost like, I think you could almost look at someone's lab panel sometimes. You guys could agree or disagree, but you can almost look at someone's lab panel and probably their DEXA scan. And without even looking at their testosterone level, you would probably know, as long as they're not enhanced, you probably know pretty good range where their testosterone is, even based on looking.
I'm rarely surprised when I look at a hormone panel at what their total and free T is. Like, I'm usually like, yeah, that makes sense. I mean, there are ones I love seeing are like my 70-year-old guys who have like a natural 900 and they're just like crushing life,
Oh, yeah.
Always make comments on those. But
well, to go on that, like, so just talk about free testosterone and total testosterone. Like, I know this, if you look up Instagram, people are always like, only the free T matters, only the free T matters. And I disagree with that, actually, because I think the total testosterone is more of like a good marker in itself, just because I think you're looking at the potential for someone's testosterone aside from the free testosterone. But I want to get you guys' take on that.
I've been surprised. So, historically I'm cheap, and so I tend to only order total test. But there's been times where I've been wrong and, their total test comes back. I had one guy recently, his total test was 900 and his free testosterone was like 40. And, in that time, people are symptomatic and the total testosterone is normal. I will oftentimes get the free test level just to be like, what the hell am I missing? And that will give me some clues about what else is going on. So from a hormonal standpoint, we'll talk about sex hormone and binding globulin and probably albumin, the 2 main binders of testosterone. But it's like cortisol, insulin, and testosterone decrease that sex hormone binding globulin. Thyroid and estrogen will increase it, as well as progesterone. So it's like, now that's giving me a little picture of what else is going on in the entire endocrine system for this individual.
So, Dan, unpack SHBG, total and free testosterone, a little bit. I mean, it's essentially, the testosterone needs a buddy to ride around in the bloodstream with, and it gets bound up by these proteins, right? And helps shuttle it around, but then that makes it not bioavailable when it's bound to SHBG. Is that the right way to think about it?
Yep. So, and don't forget about albumin. So that albumin is the most abundant protein in the body. So the albumin is a protein, sex hormone and binding globulin are a protein, and testosterone just gets transported around the body, bound to one of those vehicles. So it's like the Uber of testosterone is those 2 things. Well, if I don't have enough cars to transport those passengers around, more of it is going to be out in the periphery. It can actually do its job at the receptor and bind to the androgen receptor site. So it's, anything that modifies albumin levels, meaning you're under eating, or sex hormone and binding globulin levels, that's other hormones, stress, insulin resistance, is going to greatly impact your available testosterone in that setting.
So you think that SHBG, like what are you looking at in terms of like a range of SHBG that, is there an optimal, I guess is what I'm asking, of SHBG, or does that float up depending on if someone has a high test level, they can have an SHBG that does float up higher and that's acceptable for you? Or is there a level that you're actually looking at to keep your patients in?
Yeah, so the short answer is no. I don't freak out if someone's high or low. There is some literature to support that a higher sex hormone binding globulin level is correlated with longer life or mortality. I mean, it's the same thing with like DHEA, which is another weak androgen made by the adrenals. But do I put a ton of credence into that? No. So do I have an optimal SHGB level? Like, no. is the short answer. I'm not sitting there awake at night. Like, how do I optimize this person's
Yeah, I don't think
level?
about it. I think about it like you. It's like a clue that maybe there's these other things going on, but ultimately it's like, I think the bigger drivers that I've started to come to appreciate more is just like, you're going to drive up the total T. Even if you have a slightly higher SHBG, you're going to have more free test as well, right? So that should be your primary goal. But I do think it's super interesting, and I think where this will evolve to over time is understanding both the sensitivity and the number of androgen receptors that we have. The one factor is having enough free testosterone floating around the bloodstream. The second factor to that is like, where's it actually going to bind to actually do its job? There's interesting studies, like I reviewed one last week, that high intensity interval training primes muscles for translocating androgen receptors there. So there's good science to suggest you should like do a little bit of HIIT before you go into a hypertrophy session, because you will have more androgen receptors available there. So, that kind of, those kinetics of receptor sensitivity and number at the muscle site or wherever it's going to bind is something that's going to be interesting to see how we use clinically over time. Right now, though, I think we kind of have to dumb it down to some of these macro level metrics like total and free test.
Yeah,
Agreed.
totally. I mean, on that, it's like the androgen receptor CAG repeat test. Have you guys seen that at all? That Merrick Health does. So, have you done that at all? Down anybody? Any of these
I haven't
androgen
ordered
sensitivity? Yeah, I mean, it's fairly new. Had you heard of this before?
Yes.
So, it's super new. So, you basically just kind of described this thing. You're kind of looking at androgen receptor CAG repeats, and essentially like have a bunch of these or tons of repeats means you're less sensitive to these testosterone. Maybe you could actually need a higher level of testosterone to be effective, versus like less repeats, meaning maybe you do a better on a lower dose of testosterone. Maybe the lower level of that testosterone in your blood actually is okay for you because you have this androgen receptor sensitivity. I wonder how that's going to actually affect how we administer TRT, but also kind of how we view some of these numbers, whether they're low or higher. It's almost like a better way to assess someone's testosterone status, aside from all the other things we're looking at too.
Yeah, I mean, the bro science on that is, and this comes from powerlifting world, is your guys who look more androgenic. So hairier, bald guys tend to be more responsive to testosterone. And like, the hypothesis is do those people have lower amount of CAG repeats just based on phenotypic expression? Like, do I know the answer to that? Hell no. But, from a performance standpoint, there are radical differences in people's response to anabolics. And I would still say like probably 10 to 25% of people who I put on it, like they go on with the expectation, this is going to change my entire life. And they come back and there's just not the clinical response you would expect to see after initiation of therapy.
Before we roll on just full on starting someone on TRT, I want to know, what is you guys' best testosterone redemption story? Like, what's the best guy you took from 200 to 1,000 or whatever it looks like, and what did that protocol look like briefly?
I've had a couple of these. I mean, I'd say the most dramatic ones are not the unexpected ones, meaning these are the guys that lost 50 pounds of fat, did the hard work, were in the gym. You look at the DEXA and they put on 20 pounds of muscle. And on top of that, they're starting to do all the right things, right? Like they're getting their sleep dialed in, we're dialing in with their diet and their workouts, and maybe giving them some boost with some of the supplements or whatever. I mean, using TRT, I've definitely gotten plenty of guys to a very, tip-top level, but natural wise, I'd say I've had several handfuls of folks that we've taken in that, but it's the long game for sure.
Yeah.
And
I don't know.
Is like, I don't think they went from 200 to 1,000. We could definitely double, maybe triple that even. Like if someone's at 250, you get them to 600 or 700 through like a lot of lifestyle work. And over the course of a year or two, that's probably realistic if people are trying to like understand the level of magnitude of impact.
Dan, what do you got?
Most extreme story? I mean, I didn't guide that. No, I was like, what's the highest level I've ever seen? You don't want to know the answer to that. But
God,
what is it? I do want to know the answer.
I mean, they're unreadable. Like, I mean, I think I've had one that I think Quest is the one that will actually still quantify it, and it was like 4,500. And one of my training partners
mistake, like,
it's always I've never seen an overdose, and I'm going to give you here's a case example, which is an extreme story. So one of my training partners, we had a powerlifting meet in a week, and in typical his fashion, he's like, I'm just going to dump all the remaining test I have in my arm because that's going to get me performing optimally. So he injected 20 cc's of test into his shoulder, and then he just got a big abscess, right? So he had to go in the ER, they drain it, and oil's just pouring out.
Incredible.
And the worst part is his wife is a damn pharmacist. So it's like, she didn't say, hey, I think this is a bad idea. Yeah, no. I mean, that's probably the most ridiculous story I have. But to Deep's point, like the other thing too that I recently heard, and it's a concept I've been thinking of, I call it the Genghis Khan theory. So it's like men who are have a lifestyle where they view their life completely out of their control tend to have a suppressed testosterone. So if you're in some entry level position where you don't have autonomy, it's lower. When you get out on your own or you are in a CEO position or an entrepreneur position, it tends to go up. Okay. And you tend to be more driven and focused in that environment. So I think people think about it like a chicken or egg, like high test guys are going to go into high risk positions, gambling, entrepreneurism, but I tend to see the latter. So people, as they climb that corporate ladder, their level just goes up regardless of what they're doing from a lifestyle standpoint. So that social hierarchy also greatly, in my experience, influences testosterone levels.
Yeah, I mean, I totally agree with that. And I think I've seen people describe it as like this epistemological sort of driver of testosterone, or just archaeological. Just what is the point of testosterone, right? Like, why did we need that from an evolutionary standpoint, obviously for recreation and for sperm and just keep the population going, for all these other things like our muscle, but there are these physiologic or psychological aspects too around leading people. And, I don't know if you guys have seen these studies recently on like when people's testosterone levels change, they notice like their political opinions changed, and their opinions of basically like the biggest one takeaway was people stop caring about what others will think of them in their decision making and make decision making more based on their actual truth and how they see the world, right? Like there is a really interesting extrapolation of that to society when you think about what we mentioned at the beginning, where low testosterone levels are clearly there across all sorts of decision-making entities. What would it be like? What would society look like had we not seen that decline, or if we see us get back to those levels, right?
Yeah. And a couple comments on that is, one thing I see is, partner selection changes, aggression increases, but I'm going to give you the opposite example of 20 cc's is I have guys who are on androgen deprivation therapy for prostate cancer. Their level is literally 0 and they're completely healthy because they're doing the rest of the stuff well. So they're getting sleep, social support, working out consistently, and they can still thrive in that environment with no testosterone. So it's not like if you have a level of 0, you fall over dead. Or do they probably have some symptoms? Absolutely. But people who try to maintain good health despite having 0 levels can still feel okay. And I think that's the misconception is if my test is 200, I'm going to feel like trash. I have guys that have levels of 250. And, when we talk about lack of knowledge on an androgen receptor standpoint, they still have libido, still put on muscle mass and function just fine. So yes, there's a clear correlation. Like the higher level you put on muscle mass, you tend to get an increase in strength, but you still have variations in people. The comment I remembered was the CEO comment. So if I have someone who's making large strategic organizational decisions and we're having this conversation about starting, I tend to tell them, make sure you have checks and balances on your decision making because you may get more impulsive. So, if we're talking people who are making very large transactions with 1,000 employees and it impacts a bunch of people, like your decision making will probably change when you get put on testosterone.
That is fascinating. I guess to that point too, the reverse probably applies, right? Almost like Deep was kind of implying where it's like, if you see someone actually go down, if the testosterone was at 800, it dropped dramatically, would you see kind of this reversal in like decision-making process to the other end of that spectrum?
Well, I think that's what that is.
Yeah, that paper, right?
Yes.
The paper you're talking about, yeah.
Yes.
Yeah, I mean, hormones have a profound impact on the way we view the world and risk. And it's subtle, right? Like, you're still the same person. You're still
Hmm.
made from the same fabric, but your values and the lens through which you see the world can change. And I see this in patients sometimes too, as their levels fluctuate and change as they go through this journey. The thoughtful ones are trying to understand how their psyche is changing through this journey as well.
Well, I guess to kind of, since we're talking about putting someone on TRT, what do you guys look at and like, what's the decision making process when you decide like to put someone on a therapy, whether it's injectable, oral, whatever? Like, what steps do you need to make before you actually make that decision to put someone on, let's just say, injectable TRT for now?
Guideline-based answer is, being textbook, you're supposed to have 2 low levels below the level of 300 or 350, depending on the guideline that we're looking at, and clinical symptoms. The approach that I take, whether it's testosterone or any therapy, is does this person actually do what I recommend from a lifestyle standpoint? And so I think about it in this context of pain, and that's mind, body, and spirit. So it's like if you have tons of physical pain, you have no energy, you want to lay in bed if you break your leg. If you're severely depressed, it's the same thing. So they don't have the energy capacity to kind of get over that kind of enzymatic hump to actually change how their life looks. So, say I have a couple appointments with a patient, they have the lab levels at that point, they've done nothing. It's like, even if they're like, hey, I naturally want to increase that, I can say, well, so far to date, we've continued to dial down the lifestyle recommendations and you've been unsuccessful. Maybe you need something to push you over the hump and actually give you some energy or capacity to make a change. And that tends to be the framework I use more than are you symptomatic and do you have levels? Is it impacting this person's function and capacity to actually make change in their life?
Yeah, I think that's a really helpful framework and a similar way to how I see it. People have to prove, I think, that they're willing to do the hard work. I think the first thing is like, do they have an indication, right? Like, are they actually truly hypogonadal? There is primary hypogonadism, secondary as well. Primary meaning your Leydig cells in your testicles are not able to create testosterone. Secondary meaning you're not getting the signal from your brain down to your testicles to actually produce that. And so you have to sort of do the investigation, understand that's why we get LH and FSH and all these other things that kind of go with it and understand what is driving that. There are men who are on the lower end of the spectrum, right? In the 400s. I'd say that's probably the most common one where they seem to have all of the classic symptoms and they're telling me that we've ruled out other causes like thyroid, like depression, like whatever else, right? And now we're kind of left with the one smoking gun here. And then we have to decide how we're going to approach this, right? Like, we do think that you could feel better if we doubled your testosterone from 400 to 800, or from 250 to 500, or whatever it is. How are we going to approach that? If this is someone who has consistently shown that they're not going to change their habits around sleep, that they are still eating poorly, that they're not able to stick to a normal regimen, we start that person and they're 50 pounds overweight on testosterone. Like, they're just going to aromatize a lot of that into estrogen and feel even worse. The metabolites of this, when you're not at the right place, make people feel worse symptoms. I think the trickiest thing is what Dan sort of mentioned, which is like, okay, someone's committed to this. They're making some changes. They still have some, work to go. They're willing to put the work in. Like, do you start that person on TRT to give them that boost and to give them the energy they need? And it is definitely chicken or egg a little bit. We're talking about with patients. Like, if you lost more weight and put on more muscle, you would probably have more testosterone, which would be this virtual cycle. But if you can't get there and you've been struggling for 3 years, like, at what point do we try to help people with that, right? And kind of give them that boost. So that middle ground, that gray zone, I think is the trickiest one to approach. But if folks haven't shown that they're even able to do sort of the basics around lifestyle, then more often than not, starting TRT is just going to make things worse.
Yeah, I like that because I mean, it just goes into how we practice anyway. It's just everyone kind of gets their own personalized individual evaluation, and that's kind of the best way to approach any of this stuff anyway. So, is there a time where you taken someone off TRT, or even an indication that you've removed TRT from somebody? Not like not I'm talking not bodybuilder, like super physiologic, but just normal TRT.
The most common answer to that is prostate cancer. So, like in that, you're kind of forced just based on the oncologist. And I think, once you get into, I've passed this patient on, they're actively being managed by an oncologist, I tend to defer decision making around that to that provider. So it's hard because some men, like even with metastatic cancer in my position, they've gotten, you medically castrate them, they get diabetes, they have all of these downstream metabolic effects of not having testosterone, and they have very poor quality of life. And I'm like, where do we go from there? Other people, it's like historical past, misuse. Technically, the answer is like, how do I get them from what I'll say is performance enhancement dosages down to a TRT level? And it's challenging. So there's this psychological trade off of guys mentally tend to feel more locked in and better at higher doses that might be causing downstream negative effects. So if I have a guy at 3,000 or 2,000 levels total T, like, do I really think that's improving their metabolic health and cardiovascular health? Yeah, probably not. So kind of weaning them down tends to be more of a challenge than sometimes even just discontinuation. Some guys are like, hey, I want to have a kid. I've been blasting, whatever, 300 to 400 a week of test. And now my goals have changed. 20 years old, I want to be as jacked as possible. 30 years old, I want to start to have a family and I'm tired of my testicular atrophy. How do we get off of this? I'm sure we'll talk about that too.
Yeah, sure. Deep, anything there?
I agree. I am curious to hear, Dan, your take on sort of reconstituting fertility for a lot of these guys. I mean, we've often started people on HCG or clomiphene or something like that in addition to the TRT. But what's your approach there?
Yeah, it's tough because it's individualized. Like most guys, that's the first question I ask them. Do you want kids or not? If they're kind of like, if they've had a vasectomy, it's easier for me to justify, like, I don't care what age you are, you've made that decision, you don't want to be on it, here are our choices. If a guy comes in, they're on TRT, they're not committed to getting off of it, at a minimum, I put people on both Clomid and HCG. I know Atia has his opposition based on, the cholesterol sterol levels of being on that medication, but I think most people, from the quality of life standpoint, if you want a kid, how do we increase the likelihood you'll be successful later on? It's doing that. The other answer is just transitioning forms of testosterone. So I think one of the problematic things with the injectables is if you're just doing once weekly injections, you're getting the spikes and troughs. If you're going with, more frequent injections, the oral administration, or even the topical, like daily or twice daily, you're getting more stable levels. The Jatenzo, which is one of the testosterone and decanoate oral pill reps, they're trying to put out a study now looking at that question and saying, do we get less LH and FSH suppression over time with the orals versus the injectables? And his current answer is yes. So, I think Natesto, that's what they try to claim too. I just never use the nasal administration, but they'll say the same thing, is there's less LH, FSH suppression with other variations than just doing once weekly injections, or how it's written, once every other week or once every 4 weeks, for injectable. I think
Right,
to me, I
right.
think that's dumb.
Yeah, I mean, I think one of the takeaways and points here is that starting TRT is not a life sentence for not having children, right? Like there's a common misconception that once you're on TRT, you have to stay on TRT forever. No, you don't. You can transition off. And that you are infertile forever. No, there's ways that you can actually stay on TRT and still be fertile. And there's ways to sort of thread that needle as well. I mean, we were talking about some of the contraindications essentially, or when you take someone off, right? Like if they have prostate cancer, if they're looking to have children, you alter their regimen. There are other side effects. People sometimes will get inflamed liver or kidneys. Some of the oral forms, they used to be really harsh on the liver. I think the ones that you're talking about, Dan, the undecanoate, are absorbed by intestinal lymphatics, and so they bypass first pass metabolism in the liver, and that's why they don't cause some of these issues. One of the interesting ones that we always counsel folks on is just hypercoagulability, right? We follow their CBC, and we tell people to donate blood a couple times a year and keep their H&H below a certain level. I think one of the most striking visits I made in the past couple of years was coming to visit you and Dr. Serrano in Serrano's office several months ago. And he was talking to us about the H&H piece and letting that ride a little bit higher. I'm curious how you manage sort of elevated hemoglobin, when you're managing testosterone, what your sort of limits are, how you counsel patients on that?
Yeah, we practice a little bit different there. Speak for him and say how he practices. But the most common reason I see that is uncontrolled sleep apnea. So whether it's
Mm.
mild or moderate, like if I'm seeing a rise in hemoglobin, that tends to be I have worsened someone's sleep apnea. My proposed theory for that is testosterone increases the size of sebaceous glands, and one of those being your tongue. So when we're talking about the mouth, it's millimeters of difference can change the severity level of sleep apnea. And when you're hypoxic, the body naturally raises hemoglobin level to improve oxygenation. It does not like to be being kind of suffocated to death at night. Step one, it's like order a sleep study and see if this is reversible. I tend to kind of be in the ballpark of like 18-ish. Definitely, if it's 19, 20, yeah, do your blood donation, try to minimize that. Some of
But
that tends to be
18 or lower, you're
whatever.
mostly okay letting it ride, and especially as long as you've ruled out other things like sleep
Yep.
apnea or other hypoxia. Yeah.
Yeah,
Interesting.
same thing. So even if I'm seeing, probably plus 17, you have two options. One is lower the dose or see if something else is pushing that hemoglobin higher. Most common culprit, sleep apnea. So it's like, can you change sleep position? Do you need a true sleep study, oral sleep devices? Like, what level of intervention do we need to go to kind of control that? Because the number one thing that impacts a natural testosterone level is sleep suppression. There's one study they always cite: a sleep deprived soldiers for a week at 4 hours a night, testosterone decreased like 50%. So I just think that sleep quality is underappreciated in people. And I think there's a direct correlation between someone's natural test level.
Yeah, really, I get bothered when I guess TRT clinics or any other clinicians sort of just have these guys donating blood like way too much, like probably like, I don't know, 16, 17, freaking out, go give blood. And I think it's kind of like you said, Dan, that's kind of where you're getting at, right? It was like, you don't need to donate blood at these levels. Like, is there a point where you would have someone donate blood? You said 19. Is that the point? Even if you've ruled out sleep apnea, those kind of things?
Yeah, I mean, to me, the appropriate answer is like, look at the labs. Like, if this guy's coming back and their test level is 1500, like, the right answer is lower the dose of the medication, right? And remember, guys on high doses of TRT tend to be a little bit stubborn. And, that's kind of an overstatement. So they don't want to do that. So number one thing as a provider, just educate them. Okay, in my opinion, you are increasing the coagulation risk. Okay, so what am I going to do? Sometimes I'll do, like, if they're completely resistant, at a minimum, I'm like, well, take an aspirin a day and pray to God you don't have a clot. But I do think there is an increased risk. The dumb thing people say is polycythemia vera increases. No. Okay. You're not getting a blood cancer from testosterone. That's well known. But do you get polycythemia? Yes, you do. So it's just monitor that is how I approach it. And then again, it's talking to the patient, like, what are you willing to do? One of the things I've had to talk to an attorney about is, bodybuilder patients are taking excess use and coming up with a documentation plan of how do we get this person in a normal range? Is it ethical for me, instead of them getting, fanny pack testosterone, putting them on a comparable dose to initiate and then doing a controlled decline over time? And how much risk am I taking on? I called the state pharmacy board asking this question. And as long as you have a documented plan to get them into a more therapeutic range, you're generally protected if you're following it. So, like,
Dan, have you actually seen, like, say someone's H&H is fine, they don't have any prostate, like, you're not seeing any side effects, but their total test is like 1500 or 1800 or something. Like, is there actually a negative impact to that physiologically? Or do we know, like, do we have studies that show that?
No, I don't think we know the answer to that. And that's where it's hard is, whatever, the transverse trial.
The context is exactly what you said. These guys will come to us sometimes, they feel great, but they're like riding high. And I don't really see another reason to bring them down other than like, well, you're above 1,000.
The textbook answer is they have increased fracture risk. And that came out of the transverse trial. Like, that was what got blown up. And again, it comes to impulsive decision making, less control, I'd say less frontal cortex from the decision making. We just do dumb male stuff.
So it wasn't like that bone mineral density went down. It was literally that people were doing more dumb shit and hurting themselves.
Yes.
Yeah. That's incredible. What do you see as other, like, I know gyno is a massive fear amongst dudes on testosterone. And I think this has gotten a little better in the last 5 years, I would say, with not every single guy needs an AI. But are you doing any sort of gyno mitigation? Are you worried about that stuff? And how do you approach that when guys ask you?
Lower the dose is the answer. So, I mean, like now, like I personally in my practice do not use AIs. I think estrogen is cardiovascular protective in men. When
Me
you look
too.
at the ITP, 17 beta estradiol is one medication of like the 10 on the entire market that improve longevity. So I'm not a huge fan of artificially lowering the dose to maintain someone at a higher test level. So some people, what they're doing more commonly now is you keep your baseline test at as high as level you can tolerate, and then you're using a different agent. It's Primo, any of those types of drugs to get the androgen level higher without the side effects on the back end. Like, do I think this is quote unquote good medicine? Like, no. But it's like if I'm trying to play that risk benefit trade off, that's how I play it, is lower the testosterone dose and say, hey, maybe there's other options that are out there.
Yeah, I 100% agree. I love that we moved in the direction where not every guy needs an AI. I feel like I said, 10 years ago, I had a bunch of friends on testosterone and they're absolutely freaking out if they missed their AI dose, thinking they're going to get gyno like the next day. And I was always having
Well,
to
it
talk them
also
off a
used,
ledge.
I mean, people used to think that like we should have lower estrogen levels, right? Like
Yeah.
that's not manly or whatever, right? But there's all these studies around cardiovascular, bone protection, everything with higher E2. So I like when our patients, as long as they're not having side effects, you know, they're running in the 40s and 50s even in their estrogen. I think that's fine. But yeah, what we don't like is layering on one thing to treat the side effect of another, and just, you know, it's a cycle, unfortunately.
How do you guys feel about the microdosing thing that's been coming out? The everyday kind of sub-Q, lower dose dosing of testosterone. Are you using that stuff? And what are your thoughts?
I've used it on a couple patients. I do think it's more annoying to inject oneself more regularly. There are studies around subcutaneous versus intramuscular, and subcutaneous is mostly the same. Dan, I'm curious, like what oil or compound thing that you mix your tea with, I think can see much lower dosage to achieve the same effective testosterone levels over time by doing like a once daily lower dose of like 10 or 15 milligrams versus like, you know, 100 twice a week or something like that. What have you seen, Dan?
Yeah, I mean, the interesting thing is when you look at the literature, it's like testosterone cypionate, which is the most common one on the market. Your half-life is 7 to 10 days. The other one is Zyosted, and I think it's 4 to 7 days, and that's anathanate. And it's like stable levels. I really don't like the peak and trough. And my current hypothesis or theory is that the less consistent levels where you're spiking and decreasing, I think leads to a lot of problems on the back end. And so it's patient tolerance. And when you look at testosterone and pricing, you know, testosterone cypionate is probably the cheapest of the TRT options. So you're looking at about $50 for a 10-week supply of the stuff at a dose of, you know, 1 cc a week. So if someone can tolerate, you know, smaller doses of an injectable on a 2 to 3 time a week or daily, great. I'm all for that. Do I think it's probably a better option? I do. It just kind of, now you're in patient compliance world. Is the person actually going to do this? When you talk about needle size, I've got some guys that are trying to blast it through an insulin syringe. Well, it's viscous, and their damn thumbs now have arthritis because they've been
Like
sitting there for
what
30
is your
minutes.
actual, like, what do you actually use for supplies? Do you give folks like an 18 gauge or something to draw it up, and then a 25 to inject, or what do you actually use?
Yeah, I mean, the normal thing I'll do is most commonly when I'm initiating TRT, I'm starting on a half cc. And the reason for that is, you know, when I used to start people on a cc or 200 a week of test sip, I had problems. So I've gotten, you know, I've not a long career, but, you know, the first time I was with Serrano was in 2015. I was at the sexual health clinic at Ohio State. So I've seen thousands of guys on some form of testosterone replacement. So the incidence of problems is just high, and I've gotten a little bit more conservative. So starting dose is typically around 100 cc's, whether it's Zyosted, which is
100 milligrams, not 100 cc's, right? That would be
sorry,
crazy.
yes, 100 milligrams. Thank you for the clarification. And then I modify based on how they feel and lab values on the back end. So supplies was the original question. Typically, you're going to get, you know, 3C syringes that come on like a 25, sometimes I'll go higher, 23 gauge needle for the actual injection. And then I'm using an 18 for the fill. Again, are you getting a 1 cc vial that's supposed to be one-time use versus a 10 cc, and you're jabbing in an 18 gauge. And now you got rubber particles in your testosterone that you're injecting in your belly. If it's a 10 cc, sometimes I'll just say, draw and inject with a 22, probably is my most common. But if it's just a 1 cc, yeah, draw that crap with an 18 gauge. Don't destroy your thumbs, and then do the injection with the smallest gauge that you can tolerate.
Super helpful, practical advice and guidance there. I think one of the things that guys have a lot of the questions on is just about injecting themselves, right? Like that's a big psychological hump to get over. And I think the orals, we'll see how the data plays out over the coming years, but I'm hopeful that that will at least open the aperture for the number of people who should be treated. I do think we are probably under treating hypogonadism. I think your average PCP doesn't even check this stuff. Most guys, when they come to us, tell me like, yeah, I've been asking my doc to check my levels for years, and they just flat out refuse, right? And a lot of that is because not sure what to do with it, or they don't know how to manage it, or maybe they don't want to see the fact that so many of their patients are not optimal here. But great practical advice, Dan. Thank you so much. Any parting words for guys thinking about starting testosterone replacement therapy, or where they might go to learn more information?
Yeah, my standpoint is don't just do it because your friend does it. Okay. Lifestyle is always the answer first. If you do not have symptoms, you don't need to be on a subscription plan for testosterone, as most people are. And so it's just like, to me, it's just common sense. You're not less manly if your levels are lower. And this is one component of your health. Do I think it can radically change one's sense of well-being and quality of life? Yes. Do I think it's a cost-effective therapy that has a lot of good impacts over time, most particular improves skeletal muscle mass and thus improves your metabolic health? Yes, I do. But does that mean everyone needs to be on it? No. A lot of the supplements out there, we didn't really touch on that. Just be careful. Go with a reputable brand. I don't know if we're allowed saying brands we like or whatever.
Yeah,
but
go ahead. I mean, we don't have
yeah,
any like affiliation with any of these brands. These are just things that we think are third party tested and seem to have high quality. So you're
yeah.
welcome.
So the short answer is don't buy your test boosting pill from a gas station because it's probably just methylated test. And, when you talk about T boosters, I want to say there was a study that came out, it was like 25% of them had an androgen in them. So
Yep.
it's like, just be
And
wise.
just explain to people like that means they're just basically like grinding up animal
It's methyl
androgens.
testosterone. It's methyl testosterone. So it's this oral stuff that is bad for your liver. They're
Yep.
just throwing in there because it works.
Yep.
So, nutritionally, we didn't talk about magnesium levels, zinc levels, and fish oil and vitamin D. Those four things probably have the best evidence
I agree
for
with
being
those.
a natural testosterone builder. Okay. So it's not a lot of your botanicals that have very poor results on the back end.
Yeah, a lot of
Maybe
people ask us about Shilajit and Tonkat Ali and all these other things, right? But say the four again: vitamin D, magnesium, omegas,
zinc. Yep.
zinc.
Zinc.
Yep.
And it's
Those are
like,
the four.
well,
Boron
supplement
is
those.
maybe one other one.
Absolutely. Yeah. Boron's important as well. And there's some proprietary products on the market that combine all of those things, and they'll throw in kind of your nutraceuticals or whatever you want to call them, botanicals. I'm not opposed to those things. I don't even remember the product on the market now. It's the combination of everything that you said. It's the Shilajit, it's the Tongat,
Yep.
and then all of those vitamins. It's about $50. Do I think it's a bad supplement for people? No. If it works and you don't want to take a medication and you got disposable income, go live your life. That's kind of my perspective, but do the basics first.
I agree. I agree with that. I mean, again, just to say it, like I've never started someone on a testosterone booster supplement and taken them from 250 to 900, right? Like maybe it was all the other things that they did as well in combination with that. But I do think we widely underdiagnose, we probably undertreat, and that our population at large is probably suffering from a decline here that seems quite objective. And so we are going to continue to see this, I think, as clinicians, as a clinic, and patients come to us all the time, not just for hormone optimization therapy, but as one pillar of their overall health. It's one thing that we work on in combination with all sorts of other things. And we've got great folks on our team like Dr. Fosselman, access to endocrinologists, urologists, other people, gynecologists, women's health team. So stay tuned for another episode on women's health optimization as well. We will have some of our other wonderful Velocity Health clinicians and physicians here to talk through some of that. And make sure you like and follow. We are excited to continue bringing this great content to you and having high-level intellectual conversations about everything that impacts our health and wellness. So thank you again for joining us here on The Ultimate Asset by Velocity Health, and we will see you all again next time.
Thanks, guys.
This podcast is for informational purposes only and does not constitute professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or before making any changes to your health regimen. Never disregard professional medical advice or delay seeking it because of something you've heard on this podcast. Reliance on any information provided in this podcast is solely at your own discretion. Thank you for listening to The Ultimate Asset. Until next time, keep investing in your greatest asset, yourself.